Hello, everyone. Thanks for joining. This is going to be a really quick session. It's part of our urgent eye care series, and I'm going to talk about just corneal abrasions and foreign bodies today. We'll have a more in-depth discussion at a later date about blunt injuries and sort of penetrating injuries. But I just wanted to do a sort of quick one on this. For those of you who are just starting off in ophthalmology, and also if you're not actually in ophthalmology and you wanted to just sort of quick run through as to how we think about these and what we can do about them. Um, so your typical story would be a young man who's sort of come in, he's a builder and he's just got some sudden pain. And this is the usual story, or it's a gardener, or it's somebody who's just doing some gardening and something flings into the eye and they have now kind of pain and blurred vision. And as you can see from this guy on the left-hand side, what he's doing super, super well is drilling above his face with absolutely no eye protection. So he's basically a sitting duck for something to fling downwards into his eye and cause some problems. So when you do have a foreign body, usually you're going to come across something similar to this. It'll be like a metallic foreign body, or it might be a bit of a tree or a bit of plastic lodged into the epithelium in your sort of anterior stroma. And it's not really going to cause any other problems. Your cornea would otherwise be clear. The eye might be a bit red and irritated. It'll be a bit watery, and you're just having to remove that. But when you are approaching these foreign bodies, it's always important to just still have a framework in your head as to how you assess them. So having a vision and a pressure can be really helpful. The pressure can sometimes be an indicator that, for example, do you have a kind of full thickness laceration of the eye? Is the pressure quite low, or is the pressure quite high? And sometimes that's because of a really kind of big inflammatory drive that happens because of a traumatic uveitis, for example, or as we'll discuss in a moment, potentially even an intraocular foreign body. So you really want to get a good history. What was the mechanism of injury? Was it high impact? Was it something at high speed? Is it something like a drilling incident? Or is it just somebody who was, for example, walking and they just accidentally walked into a branch or something like that? And you want to consider whether or not you're looking at something that's high risk for it to have actually gone through the cornea entirely. And you also want to kind of understand what the material is. Is it metallic? Is it an inert piece of plastic? Is it an organic foreign body? Is it a fingernail? Is it a branch? Is it a leaf? And then you want to take a close look at the cornea on your anterior segment. So with the cornea itself, you kind of want to see obviously where is the foreign body, how big it is, how deep is that foreign body, is it sort of kind of full thickness? Is there any kind of evidence of any leak? And actually, sometimes even just a simple foreign body can actually still have a very mild inflammatory response in the anterior segment. But one of the things you might want to bear in mind is if, for example, the inflammation that you're looking at is completely out of proportion to the foreign body that or the history that you have. I had a patient once that had a history of a kind of simple drilling incident. You could see a foreign body in the cornea, but he had a huge inflammatory drive, like 3+, 4+ cells, even a slight hypopyon. And that's really sort of kind of raising alarm bells as to what you think may actually be going on. And actually, is there an intraocular foreign body? Do you have a complete sort of intraocular response? And is this kind of verging on endophthalmitis because of the foreign body? And some of the things that might kind of lean you towards thinking that you might have an intraocular foreign body is, for example, looking at the iris. Are there any transillumination defects? Do you have a cataract that shouldn't be there in a young patient? And obviously, you're also potentially going to have some bleeding and potentially even a hyphema. And that, again, we'll talk about at a later date. And then with the foreign body, with the posterior segment, again, you're looking to see whether or not there's any evidence of a foreign body. Is there a vitritis? Do you want to do a B scan, potentially even a CT scan? And if not, then you actually do have a view, then potentially kind of just rule out any retinal breaks and potentially they can even happen even from a blunt trauma as well, which again we'll talk about at a later date. So your treatment, you probably would have seen something, a blue needle or just something small that you just sort of lodge into that foreign body and just remove. And if it's a metallic foreign body, you want to try and remove as much of the rust as possible. And you can even use a burring, for example. And in the cases where you do have a lot of rust in the stroma, what you sometimes find is that you're digging away, and you just feel like you're running out of cornea. For these sort of patients, what you can do is just get rid of what you can, and then you just ask the patient to come back in a few days once he's re-epithelialized, because that rust will essentially push forward with new stroma being healed underneath, and then you can actually get rid of the rest of it after, for example, a few days. And you've essentially created an abrasion. So just basically remind the patient that this will kind of be quite painful once the anesthetic has worn off. You're going to give them some chloramphenicol ointment just to protect them, and potentially even maybe a cycloplegic, something like a cyclopentolate, just to help them with their pain. But it is just remember important to, remind the patient that they're going to feel much better once the anesthetic has gone in. But once that anesthetic wears off, they may even feel slightly worse than they did when they first came in, because you've just left them with an abrasion. So then with abrasions, again, you have a very similar approach. You want to know how it happened. You want to know what potentially actually triggered the abrasion in the first place. Is it something that's actually as a result of a trauma, or is this a patient who, for example, has an epithelial dystrophy? Is this somebody who has really severe dry eyes? Is it somebody who's recently had surgery? Is it a stitch? What's the actual mechanism as to what we think has caused it? And where is the defect? Sometimes even a simple abrasion like the one that's in this picture, right slap bang on the visual axis, can really drop the patient's vision very significantly. We're talking like literally down to 660, and it's just a big abrasion that crosses the visual axis. So don't be sort of too alarmed by low visions, but just be on high alert in terms of trying to just make sure that all you're looking at is an abrasion. But really, an abrasion slap bang in the middle of the visual axis can be quite it can have quite a high impact actually on your on your visual acuity. You also want to then sort of assess the depth and any additional features. So what I mean by this is the depth of the abrasion is quite important. Do you actually have a semi kind of half thickness laceration, or has it actually gone completely the way through? When you put the fluorescein on, can you see any leak? Are you sure that it's CDOS negative? And then in terms of the additional features, is it a completely clean abrasion? Do you have very nice smooth edges with no infiltrate at all? Or actually, can you see an infiltrate in the stroma? Is this part of something, for example, a bacterial keratitis? Are you looking at a microbial keratitis? Are you looking at a marginal keratitis? Are you looking at something else other than a simple abrasion? And the location of the abrasion, how the stroma looks, can all sort of contribute to what you're thinking is actually going on here. And then also just think about risk factors. Some of this is to do with what you think may have caused it, like an epithelial dystrophy, for example, but some of it may also be to do with how you manage. So, for example, if you think a patient is a contact lens wearer, they may have some other bugs as a commensals, and even though it is an abrasion, you may want to consider treating it with something like a moxie rather than a chloramphenicol. But that's just about the risk factors of the patient and what you think might be going on. You'll manage these patients with chloramphenicol, and usually what I actually recommend is using something like a chloramphenicol ointment rather than a drop, because it acts as a lubricant as well as an antibiotic. It can be quite annoying to use, but it has a sort of double, the dual action of it being a lubricant, and it lasts on the surface of the eye a bit longer, so the patients can sometimes be much more comfortable. The thing to have in the back of your mind is that you're not necessarily going to tell the patient that they are at high risk of developing or a higher risk of developing a recurrent corneal erosion. Um, and that's especially the case when you're looking at organic material that's caused the abrasion. So things like a fingernail, things like I said, like a leaf or a branch, and a twig, for example. These are things that sometimes are slightly have a closer association with a patient developing recurrent corneal erosion syndrome after a corneal abrasion. And you won't necessarily tell the patient that, but if they ask about complications, you would tell them. But in the back of your mind, if you have somebody who's coming in with a recurrent corneal erosion, somebody who's coming in with an abrasions over and over again with no kind of specific trauma, you may want to ask them about a history of foreign bodies or organic material sort of causing trauma in the eye in the past. And obviously, these things can be infected. Your epithelium is a very good barrier to infection. And once that's gone, you can get an infection deep seated into that stroma, even kind of dramatically further down the line, causing even something like a corneal abscess. So, this is why it's important to give them some antibiotic cover, and just warn the patient that actually you're looking for things like worsening pain, worsening redness, worsening vision. These are all reasons for the patient to represent. But otherwise, I typically discharge the patient with some chloramphenicol, and that's the same with the foreign body as well, unless I'm thinking that the patient needs to come back for further removal of rust. So that brings us to the end. Really, the whole point of this is just to say that don't be fooled by a simple foreign body history. It could be masking a much more deep-seated injury, a much more serious injury. So just take a step and just be a bit careful and don't completely sort of par the patient off just as a simple foreign body, but just be sure that what you're looking at is completely superficial. And while they are quite simple, these patients can be very, very upset. One of the things that I kind of tell my patients is, sometimes they're a bit confused as to why it's just a scratch, and they're kind of finding it difficult to believe that it's just a small foreign body, and they think there's something much more serious with their eye. And what I usually kind of explain to the patient is that so your cornea is 300 times more sensitive than a fingertip. And if you think about what a paper cut feels like on a fingertip, you've got something that's 300 times potentially worse on the surface of your eye. And and again, in terms of their visual acuity, when they're thinking, why is my visual acuity so bad? Again, you're basically telling them that you're looking through a scratched window, and that window needs to heal, and it will heal. But that's essentially why that vision is so poor. If you scratched a window, you can barely see through it, and it just needs to heal. So sometimes it's just about how you explain things to your patients, because a central corneal abrasion can feel absolutely awful and be detrimental to a patient's vision, and explaining why is a big part in the patient being reassured that they will feel better. So like I said, this was going to be a relatively quick one, just as part of the Urgent Eye Care series. Please do remember to give me some feedback. It's always helpful to A, get the feedback, and B, just see how these things are being pitched. And in the feedback, there's also a link to then suggest some things that you might want me to go through. So thank you very much for joining, and we'll see you at the next one.